Welcome to the presentation of part 3 of lecture Metabolic Bone Disease. How we diagnose osteoporosis. Laboratory data are usually of limited value in diagnosis. Markers of bone turnover are more useful in monitoring effects of treatment than in diagnosis. Also, laboratory data are helpful to exclude secondary causes like in hyperthyroidism, hyperparathyroidism, estrogen or testosterone deficiency, malignancy, and others. Methods to evaluate for osteoporosis include quantitative ultrasonography, quantitative computed tomography, but DEXA or dual energy X-ray absorptiometry is the gold standard for diagnosis of osteoporosis. DEXA is a safe, painless X-ray technique that compares bone density to the peak bone density that someone of your same sex and ethnicity should have reached at about 20 to 25 years. Bone densitometry allows doctors to detect potential problem before fracture, predict chance of future fracture, determine your rate of bone loss. All of these factors can then be weighed to determine a course of treatment. Who will be tested by DEXA? According to National Osteoporosis Foundation recommendation for diagnosis, management, and prevention of osteoporosis in 2013, anyone with fragility fracture, all women with age 65 or older, postmenopausal women younger than 65 years who have other risk factors, and men over 50 years with risk factors. Also, adults with condition like rheumatoid arthritis or taking medication like steroids should be screened by DEXA. This is the image of DEXA result. The World Health Organization criteria for diagnosis of osteoporosis defined osteoporosis as T-score less than or equal minus 2.5. T-score indicate the number of standard deviation below or above the average peak bone mass in young adults. Absolute fracture risk could be assessed by Q fracture or FRAX tool, which calculate the 10-year fracture risk. One of them will be illustrated in face-to-face session. Why we treat osteoporosis, or the goal of therapy is to prevent first fragility fracture or further fractures, stabilize or increase bone mass, relieve symptoms of fractures and or skeletal deformities, improve mobility and functional status, initiate lifestyle changes regarding smoking and alcohol. Who will be treated? According to the National Osteoporosis Foundation recommendation for diagnosis, management, and prevention of osteoporosis 2013, patient with T-score at femur or spine equal or less than minus 2.5, patients with T-score at femur or spine minus 1 to minus 2.5, this means osteopenic, whether male or female above 50 years with 10-year fracture risk at hip more than 3% and for osteoporotic fractures higher than 20%, and patients with fragility fractures regardless T-score should receive treatment. According to GB update in osteoporosis 2016, SIGN developed an algorithm for fracture risk assessment and further osteoporosis management. SIGN focuses predominantly on postmenopausal women, the most commonly affected group and the group for which there is most evidence. These are updates in osteoporosis. Please have a look. Non-pharmacological therapy of osteoporosis include having an active lifestyle, stop cigarette smoking, avoid excess alcohol consumption. Regular exercise is one of the best things we can do to prevent osteoporosis. Bones, like muscles, need exercise to stay strong. Moderate exercise, 3 to 4 times per week, is recommended. Weight-bearing exercise like walking, tennis playing, and low-impact exercise classes are best for building and maintaining strong bones. The benefit of Tai Chi in particular have been documented. Osteoporotic bone is particularly susceptible to fracture from fall. Tai Chi decreases fall among older individuals by 47%. Before exercise, patient should consult his doctor. Nutritional intervention Encourage intake of rich calcium food like yogurt, cheese, milk, sardine with bones, and green leafy vegetable like broccoli.